Auzu billahi minash shaitanir rajim. Bismillahir rahmanir rahim. Assalamu alaikum and good morning. I would like to request Mr. Sijjad to come on the stage to start with the few verses of Holy Quran.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم والسماء بنيناها بأيد وإنا لموسعون والأرض فرشناها فنعم الماهدون ومن كل شيء خلقنا زوجين لعلكم تذكرون ففروا إلى الله إني لكم منه نذير مبين ولا تجعلوا مع الله إلها آخر إني لكم منه نذير مبين صدق الله العظيم.
Stage and for the welcome address. Thank you.
Thank you very much, Afzal. Greetings to all of you and good morning. Respected teacher and our senior, our chief guest today, Professor Ziaul Islam, Professor Zia Muhammad, guest of honor for today's occasion. Some of the names are, you कहते हैं उर्दू में लाजिम मलजूम होते हैं. ऑप्थल्मोलॉजी के साथ भी कुछ नाम लाजिम मलजूम है. उनमें ये दोनों नाम उन्हीं कैटेगरी में आते हैं. तो वी आर ऑनर्ड सर कि आप लोग आए और इस एकेडमिक इवेंट में हमारे साथ शिरकत की. थैंक यू वेरी मच फॉर दैट सर. हमारे आज के एकेडमिक सेशन के चेयरमैन प्रोफेसर मोहम्मद नईम ख़ान, एज ए फ्रेंड तो मेरे ख़्याल में 25-30 साल से ज़्यादा हो गया कि हम साथ हैं. इनसे मैंने बहुत सी बातें सीखी हैं और एक बात इनकी हम्बलनेस, तारो जेंटलमैन, वो अपनी जगह. पेशेंट को इनको मैंने कभी गुस्सा करते हुए नहीं देखा. इट्स सच ऐसी क्वालिटी. हम तो जब पीडी में बैठते हैं तो सुबह स्टार्ट करते हैं तो बड़े बाबा राजा हो के न बखैर हो. 12 बजे बजते हैं तो मैं बाबा चरासी मूँगो तो दिल तो न गुस्सा ही. No, Naeem Saab actually he retired a few weeks before, but he's going to join us again. So this is credit to our department. The Professor Naeem Khan is with us, and he will be chairing today's session. Professor Sadia, very dynamic personality. इनके हवाले जो भी काम होता है मेरे ख्याल में इसके सारे वो फोकस इतना ज़्यादा होता है उस काम पे कि उस काम के होने में फिर कोई शक नहीं रहता. तो डॉक्टर सादिया, थैंक यू वेरी मच, शी इज़ हेयर. हमारे स्पीकर्स डॉक्टर अफजल इज़ आल्सो विल बी मॉडरेटिंग दिस सेशन. ही इज़ आल्सो चेयरमैन ऑफ दिस वर्कशॉप कमेटी, इज़ कोऑर्डिनेटिंग दिस इवेंट. एट सेम टाइम ही विल बी स्पीकिंग. His talk is about some growth and development. Okay. And then Dr. Raheel Malik is here. He's like elder brother. We are also golfing together. He is going to teach me a lot of how to improve my swing. And Dr. Nazli is here. Dr. Irfan is here. They will be talking about also this pediatric ophthalmology. It's a very मुझे जब मैं गया था इंग्लैंड में अपनी एग्ज़ाम से पहले अटैचमेंट ली थी तो फॉर 3 months. सो आई वाज देयर व्हेन आई पास माय एग्ज़ाम. माय सीनियर कंसल्टेंट, शी वाज आल्सो पीडियाट्रिक ऑप्थेल्मोलॉजी. शी ऑफर्ड मी पोस्ट इन पीडियाट्रिक ऑप्थेल्मोलॉजी ट्रेनिंग, पेड जॉब, एंड देन ईमेल्ड मी कि आप आओ और पीडियाट्रिक ऑप्थेल्मोलॉजी में वो करो। ये बच्चों से मैं इतना डरता हूँ कि ये दिस इज़ वेरी डिफ़िकल्ट जॉब, वेरी चैलेंजिंग। मुझे याद है मैं 3rd ईयर में पीड्स वार्ड पे गया तो एक बच्चे पे मैंने स्टेथो रखा तो उसका दिल डा 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 इतना तेज़, और मैंने कहा यार ये तो मर रहा है क्या हो रहा है। जब भाग के गया वो सीनियर के पास, मैंने कहा सर ये तो इसका हार्ट रेट तो बहुत ज़्यादा है। कहता नहीं बच्चों में ज़्यादा होता है। मैंने कहा ये अब कौन चेक करेगा कितनी उम्र में कितना हार्ट रेट है। तो समहाउ आई ऑलवेज फेल्ट कि यार बच्चों को मैनेज करना, उनकी डिजीज़ को इट्स वेरी चैलेंजिंग, और उनको हैंडल करना। जो ड्रामे आप लोग बच्चों के साथ खिलौनों के साथ करते हो ताकि उनकी आंखें चेक कर सको, मेरे ख्याल में इट्स वेरी डिफ़िकल्ट एंड चैलेंजिंग। तो पीडियाट्रिक ऑप्थेल्मोलॉजिस्ट सारे दे आर डूइंग ग्रेट जॉब। Pediatric cataract in children, again very common and challenging pathology. In a way, there is so much issue regarding that. Controversies are there. When to operate, when to put IOLs, then the complication like dealing with amblyopia, dealing with the PCO, dealing with the glaucoma related to after cataract surgery, which is one of the common. तो ये सारी चीज़ें ऐसी है कि इस दफ़ा हम सोच रहे थे कि कौन सा टॉपिक हम पिक करें अपने पीडियाट्रिक या कोई सिम्पोजियम के लिए। तो अफजल ने कहा कि नहीं पीडियाट्रिक कैटरेक्ट, जैसे इसने कहा मैंने कहा बिल्कुल दिस विल बी वेरी इंटरेस्टिंग फॉर एवरीवन। Dr. Saab, welcome. Dr. Sumaira is here. She is our guest speaker from Islamabad. Thank you very much. आपने अपने बिजी शेड्यूल से टाइम निकाला और हमारे इस एकेडमिक इवेंट को ऑनर किया। It will be pleasure and we are all hoping to learn a lot from you. Thank you very much. Thank you. तो I hope कि आज का सेशन सब इंजॉय करेंगे और लर्न भी करेंगे। So over to you, Dr. Afzal. Thank you very much.
Thank you, sir, for your precious comments. जैसे सर आपने इंग्लैंड की बात की है, सो माई सुपरवाइज़र आस्क मी कि मैंने अपने सुपरवाइज़र से ये सीखा था कि पीडियाट्रिक में जो आपको कोई पीडियाट्रिक कैटरेक्ट या कोई पीडियाट्रिक ऑप्थेल्मोलॉजी में कोई भी मसला हो तो यू लुक फॉर सम अनदर पैथोलॉजी। मेरी सुपरवाइज़र अपनी सुपरवाइज़र की बात कर रही थी कि मैंने उससे ये बात सीखी थी कि आप भी कोई कॉम्प्लिकेशन पीडियाट्रिक में देखें तो वो तो है ही, तो आप दूसरे के लिए देखें, और दूसरे के देखने के लिए पढ़ने की ज़रूरत है कि वी हैव टू नो अबाउट द रिमेनिंग प्रॉब्लम्स। सो माय टॉपिक टू सेलेक्ट द आई ग्रोथ एंड डेवलपमेंट। Why I select this topic? कि हम आई मीन एडल्ट कैटरेक्ट और पेडियाट्रिक कैटरेक्ट में डिफरेंस है, और उसके लिए जैसे हम बायोमेट्री, IOL सिलेक्शन, कब सर्जरी करनी है कब सर्जरी नहीं करनी है, सो दैट्स वाई वी हैव टू नो अबाउट द नॉर्मल ग्रोथ, नॉर्मल फिजियोलॉजी, नॉर्मल एनाटोमी, देन वी विल थिंक एंड वी विल नो कि हमने क्या इंटरवेंशन और कैसे करनी है। So I will go for the normal physiology and anatomy of the pediatric eye growth. The neonatal eye, one of the most fully developed sensory organ. The ophthalmologist caring for the pediatric patient must understand the normal developmental changes so as not to confuse with the pathological conditions. Despite its similarity to the adult eye, there are tremendous changes that will occur in the early age of life, like refractive correction, axial length, shape of the cornea, color of the iris, pupillary response, lens, retina, neurological development during childhood, globe and orbit. The globe dimension, weight and axial length. So the infant weight of the globe is 2.3 to 3.4 gram. The average adult eye weight 7.5 gram. the volume of the infant globe varies between 2.20 and 2.25 centimeter cube. The axial length of pediatric age group, the full term infant is between 16.8 to 17.5 mm. During first year of life, the rate of the growth is greatest. On average, 2.5 to 3.8 mm increase in axial length in the first year of life. So the mean axial length 20.7 millimeter. The rate of increase then decrease in the subsequent year such that the mean axial length 21.5 mm in the second year and 21.9 mm in third year of age. So in the first year, the axial length of the globe is increased fastly, which come to the almost 3.8 millimeter. While the later second and third year of age, the axial still is going to increase, but not at that much like in first year of age. So the last line means to explain. This is the MRI scan images which show the axial length of the interior to posterior, superior to inferior from the different imagings from the interior to posterior against temporal to nasal. So these are the ultrasound by microscopy you can measure the axial length, and with the MRI we can measure that. So the rate of the growth slows to approximately 0.4 millimeter per year of age. The axial length generally reaches the adult dimensions by the approximately 5 year of age. 5 to 15 year of age, there may be small increase in the axial length of usually less than 1 millimeter without the presence of myopic refractive error. The mean axial length in girls is shorter than boys. Now come to the cornea. The macroscopic and intracellular changes to allow the transparency as well as changing in the refractive power postnatally. Corneal diameter undergoes only minimal growth. Average corneal diameter horizontally is 9 to 10.5 mm, and the mean corneal diameter is 9.8 millimeter. So in cornea in a pediatric age group, we have to know about the corneal diameter, the curvature of the cornea, the power of the cornea, and transparency of the cornea. So these four things you have to be in your mind and think about planning of while if you have a patient with surgery like cataract. Today topic is cataract, so we are thinking about that. So we have to think about that. The growth in the corneal diameter is also accompanied by changes in the corneal curvature. Changes in the corneal curvature must be perfectly balanced with the changes in the lens and the axial length of the eye. The corneal curvature is much steeper in infants than in adults. So that's why when you are going to calculate the intraocular lens, so you have to think about the steeper cornea as compared to the flatter cornea. And as sir raised the question, then when we have to intervene, when we are going to plan the insertion, IUL selection, what type of IUL, so what are the complications and what follow-up we have to take. So these all things we do with all these anatomical changes. So if you look for the keratometry, so the mean keratometry is 55. So 55 diopter at full term birth. So if we have a premature baby, so we have almost 62 diopter of corneal curvature. So as about the first year of age, we think about whether in early age we have to implant the IOL, we don't have to implant the IOL, what power of IOL we have to implant. So these all the parameters which we look for that, and we have to select the IOL and surgical procedure. The corneal curvature continue to decrease rapidly. First 2 to 4 weeks of life in the term infants, and then slowly after 8 weeks of life. These are just to show the curvature. It is a steep cornea like keratoconus, but just want to say to show the curvature of the cornea, which is highly, steeper. The flatten of the cornea persists into the second and early third decades. The average keratometry at the age of 20 is 42. As I was explaining in the adult cornea and the pediatric cornea, so as you are asking and looking for the keratoconus is usually associated with VKC, so you have a steeper cornea, and if it is 46 or above, then you are label it as keratoconus and refer for CXL and or the remaining treatment options. The corneal stroma also become thicker during the first several months of life. So this thickness is also affect your intraocular pressure. If you think about the congenital glaucoma, so you have to know about the corneal thickness, that how much the corneal thickness, and in pediatric age group and early age group, the corneal thickness is more. Keratocyte in the corneal stroma decrease in thickness and density during development. In early stages, keratocytes also more, but all this become decrease in the coming life. These blue colors are cells of keratocytes and epithelium, basement epithelium layer and basement membrane. These are the stroma, basement membrane and endothelium. The keratocytes play an important role in the corneal stroma wound healing. Decrease in the keratometry density is due to combination of environmental and predetermined genetic factors, although the exact mechanism is unknown. Decrease in the keratocytes may be partially or completely responsible for the age-related changes within the cornea. Decrease in the central corneal thickness with age, stiffening of the cornea with the resulting refractive changes throughout the childhood, increased light scattering noted in the cornea with age, and also with the corneal thickness. So at the age of 12-week fetus has an endothelial cell density of 14,000 cell per millimeter, and at the full term, the average endothelial density decrease up to 6,800 millimeter square. The corneal thickness influences the measurement of the intraocular pressure. Under general anesthesia tend to lower the intraocular pressure because of that medications. So while infant in distress are crying and squeezing of the lids elevate the intraocular pressure. Since the tonopin compresses a much smaller corneal area, it is slightly less affected by corneal thickness. Intraocular pressure increases 2.1 to 3.5 mmHg of mercury with the every 100 micron increase in the central corneal thickness in the children with when measured with the tonopin. Now come to the interior chamber. So these slides are talking about the normal pediatric age group that we are normal eye to discuss. Whether if the patient have a congenital cataract or something else, so it's not in that very measurement. The interior chamber method to elevate the interior chamber including slit lamp photography, the ultrasound, biomicroscopy, interior segment, OCT, depth influenced by the growth of the sclera as well as by the factor related to lens movement and thickness. The average 2.05 mm with the range of 1.8 to 2.4 millimeter in depth of the interior chamber. The interior chamber depth is slightly deeper in boys than girls. The volume of the interior chamber in the approximately 64 mm cube in term infants and 116 mm cube in adults. So these are the biomicroscopic image which show the central corneal thickness and interior chamber depth. This LV is the lens vault, and you can see about the interior chamber angle, the peripheral corneal thickness, and these are the peripheral limbus and again the angle, interior chamber angle. Now come to the iris. Primary pupillary membrane forms early in the gestation and atrophies near terms. The color of the iris results from pigmentation of the stroma, mesodermal cells, and iris blood vessels. A term, the mesoderm stromal cells to the eye of the iris continue to develop pigments which account for the darkening of the iris color observed in the first few months of life. Many pigment-associated genes that reside on the chromosome 15 which contribute to the iris color. Now come to the lens. The tunica vasculosa lentis plexus of the blood vessel that is instrumental in the development and nourishment of the lens in the embryonic life completely regress after the 35 week of gestation. The crystalline lens is the structure most responsible for the adapting to the changing of axial length of the eye and subsequent influence on the refractive need of the eye. Structure, molecular and geometric changes in the lens that allow it to change in power, beta and gamma crystalline that make up the body of the lens. These fibers congregate in the nuclear region of the lens with the increased concentration of protein, which increase the refractive index of the lens. Thinning of the lens during the first 3 years of life due to equatorial growth of the eye, which essentially stretch the lens. Retina. Retina are poorly developed at birth, but changes rapidly during first 4 years of life. Most significant changes in the macular pigmentation. Developmental of annular ring and foveal light reflex and differentiate cone photoreceptor. Improving of visual acuity with the age is due to development of macula. Retinal vascularization begins at the optic nerve head at the 16th week of age and proceeded to the peripheral retina, reaching the temporal ora serrata by the 40th week of gestation age. Sclera, predominantly extracellular collagen matrix. The collagen in the sclera undergo developmental changes in the early postnatal period. Sclera is 4 times as pliable or flexible in the infants as in the adult and has approximately 1/2 of the tensile strength. Pliability explains the ophthalmos in the infantile glaucoma with elevated intraocular pressure. The structure changes in the sclera is due to changes protoglycan composition of the sclera. There are 3 major protoglycans in the sclera: aggrecan, biglycan, and decorine. Increase in the scleral thickness from 0.45 millimeter in neonates to 1.09 millimeter in adults. The posterior portion of the sclera shows greater growth than the equatorial portion in the early postnatal period, resulting in the apparent forward migration of the extraocular muscle insertion site relation to the equator of the eye. Lomican is a keratin sulfate protoglycan in the sclera that appear to regulate collagen fiber formation and organization. Your share dedicate ka masar. And yes, our senior professors, Sanawala Jan Sahib, Abed Sahib and Nawaz Sahib, they are all teacher of teachers.
Nawaz is a pioneer of ophthalmology in our province. He was a teacher of our teacher actually.
So this.
Yesterday he was here for checking his eyes, so we just had an opportunity to have photograph.
And this is the share is in Pashto, and it is dedicated to all my teachers. Star shajar da ilam ukara afgara. Star shajar da ilam ukara afgara che sabade biawada sore tanastwi.